So breasts, okay? Breast anatomy, they're also known as mammillary glands, okay? They're really a modified enlarged sweat gland is what it is. It just produces milk with a lot of nutrients in it. It lies on top of the pectoralis major muscle. So if they ever have to do what we call a radical mastectomy because they have breast cancer, they're going to remove the breast, of course, but also the underlying muscle. And what I teach my AMP1 students, they need to know the action of the pectoralis major muscle, because if they remove that muscle, you're not going to be able to do certain things. That's something that the patient should want to know. Doctor, after I do the surgery, what won't I be able to do? Well, you're not going to be able to, you're not going to be able to adduct your arm. You're not going to do it. It's going to be weaker. You have other muscles to do it, but it's not going to be so strong to do that. So, so that's what's happened there, and it attaches the breast tissue to the muscle, to this muscle by something called Cooper's ligaments. The external structures, there's the nipple, and then the darker area around the nipple is called the areola. The areola is a pigmented area around the nipple that's going to have oil glands in it. It's going to secrete oil so that it doesn't dry up when a baby's sucking on it for breastfeeding. Okay, so that's what this is going on there. So again, there's our breast, and it sits right on top of the pectoralis major muscle. All right. The internal structures, I'll just read them off over here, but the picture will make more sense. We have lactiferous lobules, lactiferous ducts, and adipose tissue. The lobules is what's going to, prolactin is going to, remember, where's prolactin coming from? You remember? It's a hormone that comes from, yes, it comes from the anterior pituitary gland, okay? And it's going to, so the prolactin is going to target specifically the lactiferous lobules to make milk. Doesn't inject it, it makes it, okay? Once it makes it, then it's going to go down the lactiferous ducts into the nipple, okay? And the adipose tissue is around these areas so it doesn't collapse. So let me just show you the picture. There's a nipple. These glands over here are really lobules, not glands. They're lobules over here. So these are lactiferous lobules, and they're all connected by these ducts. The ducts themselves will all converge towards the nipple. So that none of this collapses, the yellow area around here is adipose tissue, fat, to try and keep it so they don't collapse. Okay? Questions on that? That's how it's all arranged. Which, by the way, the ducts over here, this is what becomes cancerous. It's called intraductal carcinoma. Ductal, that's what they're talking about. That's what becomes cancerous, these ducts. Okay? Now, breast physiology. We're going to talk about a little bit about hormones. We already mentioned oxytocin and prolactin, right? At puberty, estrogen causes the lactiferous lobules to grow, right? That's when at puberty the girls get those, we literally call them breast buds. Not buds, but they're called buds, right? That's what they're called. All right, and fatty tissue starts to grow around them. During the menstrual cycle, we have two hormones that are going to affect here. Estrogen is going to make the lactiferous ducts grow and fill with fluid, fill with milk. Okay? Progesterone is also going to make the lobules and also the ducts fill with fluid. All right? So what happens here, progesterone, we're going to get into the menstrual cycle, but progesterone comes once the egg ovulates. Okay? So now, during the next 2 weeks, the breasts become bigger because of this. There's an engorge of milk that's happening there. The pain disappears when the progesterone goes away. That's going to be just before the menses starts. You see, we didn't get into it, but menstruation is when estrogen and progesterone are down. They disappear. So therefore, the endometrial lining starts to shed off. When that happens, the painful breast should go away during menses because the congestion goes down because there's no progesterone. Does that make sense? Can you visualize that? Okay? Hint, I will have a question about this. Okay? So pain disappears during the menses due to low levels of estrogen and progesterone. Progesterone and estrogen is going to fill the breast with milk. When you don't have estrogen and progesterone during menstruation, it'll disappear. Okay? This is just an FYI, won't ask you about this, but you have human milk and cow milk, and it kind of tells you what's found in each one of them. There's also something called colostrum. Have any of you heard about colostrum? Colostrum is the first outtake of milk coming out of the breast when a baby's born. This is really enriched with all these proteins and stuff. So the woman is not too sure, new mom is not too sure if she wants to breastfeed or not. I would tell her, breastfeed right now, at least for the first couple of days, because it's going to be high in the proteins. And then decide if you want to do it, you want to continue to do it or not afterwards. Does that make sense? Right? Okay? So that's what that is. Again, I'm not going to ask you about this. It's just an FYI. All right, some other hormones that are going to affect this besides estrogen and progesterone. Prolactin comes from the anterior pituitary gland, and it's stimulated by prolactin-releasing hormones. Where do prolactin-releasing hormones come from? Give you a hint. Prolactin-releasing hormones. Where are releasing hormones and inhibiting hormones coming from? Hypothalamus. Bingo. Okay? Always. So prolactin is going to be stimulated by prolactin-releasing hormones, and also when the baby starts suckling on the nipple itself, that also there's receptors there that will also produce this prolactin. Prolactin is going to synthesize more milk to be made. Okay? So prolactin makes milk. Oxytocin also comes out, and that comes from the posterior pituitary gland. It's actually made in the hypothalamus, gets stored at the posterior pituitary gland, and it gets released from the posterior pituitary. All right? This gets stimulated also by suckling on the nipples themselves because the receptors are there, and also when baby cries. Oxytocin is going to eject milk. Okay? It also contracts the uterus to push the baby out. So when a baby cries, a woman may notice that her breasts are leaking milk. It works that way too. Okay? It's kind of an interesting thing because the body knows how much to make, when to make, for the number of babies that you have. It's a kind of a phenomenon we don't understand. So when a baby cries, that's like saying the baby's hungry. So the breasts know that the baby is hungry by producing and ejecting this milk. And even if you have twins, there's enough milk for two. It just knows how to do this. Or at least we don't understand how that happens. At least right now we don't. Okay? Any questions about that? All right. So this is just putting it all together. You can put it all together and look at it. This is where all the hormones come out. And this is a good opportunity so that you can start studying for that final exam. So you've seen all these hormones and put this all together. Okay? Progesterone also inhibits prolactin. So think about this. Okay? Once the placenta is delivered, now the placenta actually produces estrogen and progesterone, which we didn't talk about yet. It's going to produce estrogen and progesterone. So yes, the placenta is a gland. Impressive. It's going to produce estrogen and progesterone. Once you deliver the baby, and then you're going to extract the placenta from the woman's uterus, you just took a big source of progesterone away from the mom. Does it make sense? You're removing the placenta, you're removing a big bolus of progesterone, If progesterone's supposed to inhibit prolactin, now you don't have the progesterone. So guess what? How much prolactin is going to come out? A lot or a little? A lot. Because we just removed the source of progesterone. Okay? So once we remove placenta, your progesterone goes down, prolactin goes up, and works like magic. Baby comes out, now you're going to be a producing, a milk-producing person for the baby that just was born. Okay? All right, just very fast about breast cancer, and I'm done. Okay? Breast cancer. Some facts about this. It's the #1 cancer found in women. #2 cause of cancer deaths in women. What's the #1 cause of cancer deaths in women? It's the same for men, too. No, cancer. What's the #1 cause of death for cancer in women? What kind of cancer are women dying most from? Lung cancer, yeah. You don't know that? You hear a lot of people with lung cancer. Well, lung cancer is the #1 cause of cancer deaths in both men and women. Okay? But we find more breast cancer in women because we do a screening. We do mammograms. We do self-breast examinations. Right? So we catch them early. We see a lot more of it, but they're not dying from it as much as lung cancer because we're picking them up early. Does that make sense? Okay? There is no screening for lung cancer, if you think about it. The chest x-ray, we don't do chest x-rays on everybody. Does that make sense? No, I don't get, unless there's something wrong with me, right, if I'm coughing, but breast exams are routinely screening after 35, well, after 40, but between 35 and 40, they do a base one, and then 40 years old, you just do one every year. But they don't do that at 40 years old, they do lung cancer. Does that make sense? This is not cost effective. Because the amount of chest x-rays that they do, they don't find the lung cancer there, so they're just wasting money. But they are picking up, with the mammograms, they are picking up breast cancer early, so that is cost effective. It's to do that so you can pick up this stuff early. All right? Ovarian cancer is another one that's pretty bad. We don't have a screening for that. So, like I said, it's ductal cell carcinoma, right? It's the ducts that actually become cancerous, okay? Okay? And like I said, the way we detect breast cancer is that we do self-breast examinations, all right? Not me, but self-breast examinations. We should start doing it early, usually in the shower, all right? What I usually tell women to do is that look in the mirror, when your clothes are off, look in the mirror, put your hands down like this, and see what the breasts look like. They should be symmetrical, okay, on either side. If they're not symmetrical, you would probably know. In other words, one might be higher than the other, but that's something you had probably for years. So that's not cancer. But something that's new, that's something you got to pick up on. So you look at that, and you see if there's any bumps that you could see that's coming out that are not normal. You look at it like this with your arms down. You look at it with your arms up because it kind of stretches the skin a certain way. And you see if there's anything. You can see bumps that are maybe in an area where you wouldn't have seen before. The other way is also to put your arms on the sides like this, and it would also show bumps or any kind of irregularities between the two. Then when you go in the shower, it only takes a minute to do, but then it's easier to do it in the shower with soap on your hands because you can slide and it's easier to do that, and you check in certain areas. I don't want to do it, it's not very modest for me to do that over here. But you check in those areas over there, and also check in the armpits for any kind of bumps. That's where your lymph nodes are. All right? But that's easy to do do that once a month. Don't do it every day because you wouldn't see a change, but once a month you would see some sort of a change. And you know your breast better than the doctor. So the doctor will ask you, when he does his exam annually, he'll say, I feel something here. I felt that for the past 10 years. Then chances are it's fine. Does that make sense? Because you know your own breast. If he's still skeptical, he'll do like an ultrasound of it to see what actually it is. Okay? Or a mammogram for that matter. Problem is to do mammograms if you're under 35 years old, there's a lot of fatty tissue there, and it kind of obscures a lot of things. So it's not really recommended to do mammograms before 35 years old, unless they actually feel something that's huge. But even when they feel something huge, it's better to do an ultrasound. Okay, does that make sense? All right. So they usually do something like this. And then we do mammograms. Now, I'm not going to ask you about the different ages over here because there's a lot of controversy now on when to do mammograms. The American Surgeon Society Association has one way of doing it, and then the Cancer Association has another way of doing it. And I forgot which one is which, but the baseline is usually 35 to 40 years old, and then you do a mammogram every 2 years between 40 and 50, and then every year after that. But now there's some controversy that they can do, some of them want to do after 40 years old without any risk factor, to do it every year, or to do it every 2 years. So right now there's controversy about it. You'll see it in newspapers and stuff. But if you have a family relative that had breast cancer, disregard that. You want to go every year. All right? And I'm sure the doctor did, because you're at risk. It's the question about if you have no risk factors. I mean, if you had breast cancer once before, again, you're at risk. If you had your mother or your sister with breast cancer, and there's a correlation between ovarian cancer and breast cancer too, you want to keep on doing that. Okay? So that's what mammograms are. And mammograms are a CT scan of the breast itself. This is what a mammogram is. If you haven't seen one or haven't had one before, it's a machine that's going to take the breast, so that one side is going to actually have the projector that's going to project the rays. It's an X-ray of the breast, all right? And the other side is going to have the film. And when they do this, it'll look like this, all right? So here's the right breast, and here's the left breast. And then you see something like this. It's called a popcorn lesion. When they have a lot of calcification like this, because it looks like a popcorn, that's what they call it. But that's what they're seeing over here. So that's suspicious, and then they'll send you off to the surgeon to see what he or she wants to do with that. Okay? So that's what that is. Questions about mammograms? Okay? Early symptoms of breast cancer: swelling, lymphadenopathy, which means anything wrong with your lymph nodes, whether they're big, they're painful, something like that, or any kind of nipple discharge. Does that mean that nipple discharge means you have cancer? No. But, I mean, if it's something new, get yourself checked out. See what it is. Is it something that is it hormonal related, that you're just producing like milk that's coming out when it shouldn't be? Or is it something that's bloody or even a tinge of blood in there that could be also cancerous? Okay? Late symptoms is you get nipple retraction, because what happens is the tumor that's growing is fusing with the skin and pulling the skin in towards itself. So it creates this dimpling on the breast itself. And when the whole area gets these dimplings, it's called peau d'orange. Anyone speak French here? What does that mean?
It's like for skin and orange,
like the orange skin, not the color of the skin, but like like the texture of an orange, like a fruit. That's what it looks like. I'll show you a picture of what that is. Okay. So again, this is somebody who didn't want to go see the doctor, right, and just let it grow. Here's where there's nipple retraction. See how the nipple kind of gets pulled in there? That's what nipple retraction is. All right. You can see here when the lymph nodes are affected. Now, fluid can't, right, you learned about this, where fluid can't get through the lymph nodes, so now your whole arm becomes edematous, because it can't go through the lymph nodes. There's blockage there. And you can see your whole arm being edematous, right? Here's this peau d'orange. See how, like, not the color of it, but you see how, like, there's these little dimplings happening all through here, almost looking like the texture of an orange peel. You know what I'm saying? Like the skin of an orange. It's got that dimpling on it. That's what goes on with here. Okay? And you can see when this woman had her breast removed, they had to remove some of the lymph nodes. And when you remove some of the lymph nodes because they were cancerous, you're now going to have a lot of fluid in this arm. This is something you got to be aware of, because if you have to do blood pressure on a woman who had one of her breasts removed, you don't put the cuff on that arm. You put it on the other one. Okay? If a woman had a bilateral mastectomy, both breasts were removed, then they have actual cuffs that go around the legs. And you can do blood pressure that way too. Okay? Never do a blood pressure on an arm on the same side that has the breast removed. Okay? And these are famous people that have or had breast cancer. I kind of put them all on here. Maybe some surprising ones or not. Okay? So they're all on there. But the key is different ages. I mean, here you got, 56 years old. They were diagnosed. Jacqueline Smith, right, from Charlie's Angels. She was diagnosed at 56 years old. This comedian, what's her name, Wendy? I don't know, but she was diagnosed at 47. Sheryl Crow, diagnosed at 44. Misery, what's her name? Catherine, I forget. But anyway, she was diagnosed at 64. But look, this is Applegate. What's her name? Christine Applegate. Is it Christine Applegate? She was from Married with Children. Anyway, so she was diagnosed at 36 years old. So they're all over. That's why we got to start doing these mammograms, fairly early. You don't want to, get a baseline between 35 and 40 years old for someone who hasn't had, who has no risk factors. Okay, just to get a baseline. And then at 40, that's when you would do like every year, every 2 years, whatever the doctor suggests you do. Right? But we're finding more and more women with breast cancer, but they're not dying as much because we're catching it early. Okay?